I think we're going to start. Thank you very much. Thank you very much, everyone, for attending our Innovative Discovery Seminar despite our somber circumstances. As most of you know, our friend and colleague, Sima Sonad, unexpectedly passed away early this week, and we are still all in shock and joking. So I had first some housekeeping issues that I'd like to remind everybody. Online participants, please keep muted unless asking a question. Use the chat feature in BlueJeans if you have technical questions. Previous presentations are available on our website, DE-CTR.org. Sign in to receive CME credit. Use BlueJeans chat to contact Sarah Fay to receive credit for viewing online. Our next seminar for the Innovative Discovery series will be Robust Estimation of Propensity Score. That will be on June 5th, and that's Google. Oh, that's fine. We're going to do that. I'm really looking forward to this. And then the role of mentorship in research on June 12th. That will be Rob Hopkins. And finally, the full summer schedule is available, so please grab a copy and mark your calendars. So it is my great pleasure today to introduce Dr. Jackson. Dr. Jackson is the director of the Center for Health and Delivery Science here at the Value Institute, as well as the associate director of the Value Institute. Dr. Jackson did a residency in anesthesiology and a fellowship in pediatric anesthesiology at Johns Hopkins, and has an MBA from George Washington University. He was chair of the Fellowship Advisory Committee and associate director of the Pediatric Anesthesiology Fellowship Program and director of the Simulation Center at Johns Hopkins. So in addition to chairing multiple committees here at Christiana Care, he is also co-chair of the Austere Anesthesia Health Outcomes Group and the PI on a very large grant, international grant, for safe anesthesia and safe surgery initiative in Sierra Leone. He received multiple awards for excellence in teaching and in service and has numerous publications, and we are really delighted to have our own Dr. Jackson here giving us a talk.
Many of you know, I echo maybe just retool. The events of the last 24 hours, some of us are still in shock. It took me a few moments to get my words placed. We deeply impacted by the loss of SEMA. Just to give everybody another quick update, Janice actually reached out to me about an hour ago just to see how we're all doing. So they're still in shock, but so I just wanted you to know that Janice is thinking about you. A lot of the work that I'm involved with here at Christiana Care deals with process of care issues, deals with quality safety related matters, in terms of I was still thinking about SEMA for a minute. Catch myself for a second. So the reason I was brought in was because of my background. I was told this to be it was due to building programs, sustainable programs that help healthcare institutions mitigate error, preventable harm, and reduce variability. A lot of that insight came from work that was done overseas, and where very low resource environments, where they're resource constrained, have high levels of variability and high mortality rates. And one of the things that we were able to demonstrate was you didn't need a lot of money to have a good process. You just need to actually be a process. When you live within the constraints that you have, you don't necessarily need to be gadget. This talk, however, is going to focus more on why surgical issues are an emerging concern as we think about global health. Why I'm going to make a case using some objective measures to justify that statement. Why non-communicable diseases are on par with communicable disease, and use some examples that may be familiar to you to help make that point. So just to give you a perspective, and these are just some very general numbers. There are approximately 234 million operations annually, and an operation is defined in this instance as something happening in an operating theater. Although there are emergency departments and other venues where things can happen, the term is the definition that's being applied in operating theater. About 3.5% are in low and medium income countries, and I'm going to define what that means briefly. But to put that in perspective, a third of the global population resides in this. So there's a tremendous imbalance. And to put it in perspective, 2% of the world's motor vehicles are in low-resource environments. However, those environments account for 20% of the world's motor vehicle fatalities. Put that in perspective. The work, so I'm a little off balance. Don't worry, I'll get my footing in a moment. As was mentioned, I was one of the founders of the Johns Hopkins Austere Anesthesia Health Outcomes Group, and one of the reasons we created this was there was inadequate attention to the provision of anesthesia services and its role in improving surgical outcomes. If you look at American history or Western history, most of the advances in the perioperative space were because of anesthesia. And from this, in terms of safety, for centuries, people have been trying to perform mastectomies, amputations of this, that, and the other, Civil War medicine, etc. Innovation in anesthesia practice that made it actually safe. And that really came about in the 70s. If you think back to the way people thought about surgery in the 50s, if you went to the operating room, everyone was like, whoa, that's really a big issue. Now it's commercial. People, it's now medical tourism, plastic surgery, because anesthesia has become so safe, surgery's become so safe that people actually engage in elective cosmetic activities because the risk is essentially negative. The work is supported by Gradient Health Systems, which is a entity formed by the Simons Foundation, which is a nonprofit organization. And the reason this was done was because they were interested in creating a medical device that would work in an austere setting. They didn't want to put the foundational resources at risk. So they had to create a legal framework to allow a medical device manufacturing process to take place. Turns out that this device is to provide safe anesthesia in environments where electricity is not routinely available and where compressed gas is not routinely available, which is also a big deal. Okay, I'll go into this. So, jumping around a little bit, so about 5 billion people in the world do not have adequate access to surgical services. This is a map. And this is actually data published about 3 or 4 weeks ago from the Lancet Commission on Global Health. And basically, the darker the color, the less surgical resource you have. And so this shows you the disparity that you have in terms of high-income countries and low-income countries in terms of the availability of surgical services. Just to give you a snapshot, one of the big issues is pregnancy. In low-resource settings, pregnancy is a very high-risk activity. Hemorrhage, infection, and results in a very large number of deaths per year. A lot of these deaths are preventable deaths. But every woman who dies of childbirth, approximately 20 suffer from complications. And one of those complications can be fistulas. Those are abnormal connections. So, for example, you have the uterus vaginal lining. A fistula could be a tear that happens during childbirth that could create an abnormal passage between the bladder and the vagina itself, which you can see can be very very concerning. Or you could have an abnormal connection between the bowel and the vagina also. And there are women that have had to endure this sort of thing, which could be easily repaired, status quo, had they had access to appropriate surgical care. They're often ostracized from their families, unable to engage with their marital life, and as a result, they have challenges with their spouses, and it goes on and on and on. Not to mention self-esteem issues and all that goes on with that.
Quick question. That includes U.S. data and the global?
Yes.
Global.
Absolutely. The injuries, as I mentioned before, you have about 5 million deaths per year. This is global, not just restricted to low-resource environments. Then, obviously, congenital abnormalities. And these are very significant problems because if you are in a low-resource setting, for example, and you live on a farm, well, now all of a sudden you're not a producer because you can't carry as much, you can't move as well. Transportation systems may not be robust, so you have to walk long distances. And if you have feet or malformed and you don't have access to appropriate surgical care, simple remedy, in some cases not so simple, but in many cases simple, or appropriate fittings of shoes, etc., can actually be really very transformative for So I wanted to start off with some basic definitions to make sure that we're all on the same page when we think about, when we use the term resource environment. Now, the definitions that I'm using, there are several. You have the International Monetary Fund, you have the World Bank, you have a variety of organizations that have, you have the CIA World Book, a variety of institutions that have different ways of defining income. For the purposes of this discussion, we're using the World Bank definitions because that's where the WHO kind of feeds into their process in terms of how they classify issues. So these numbers are actually, there's a convening of a group every July in terms of how they classify countries as high income or low income. The reason this matters is it deals with one's ability, a country's ability to qualify for low interest loans, debt forgiveness, in terms of how those global issues are done. So therefore, there's a tremendous amount of heightened interest in countries in terms of how they're classified. The other thing to keep in mind is that if you're, whatever classification you're in, whether it's high income or low income, does not imply that you're at the same stage of development. So we don't have a standardized, in other words, you can have countries that have extraordinarily low circumstances in terms of their resource allocation, or they could be at the top end of that category, and I'll show you what that means as well. So the other thing I wanted to talk about is the definition of wealth in terms of the taxonomy for countries. And the way to look at this, you've heard terms like gross domestic product, gross national income. And basically, this has to do with whether you're counting the income of a citizen or a resident of that country, or things made in that country. So gross national income primarily refers to a resident of that, goods and services manufactured by people that actually live in that country. So a U.S. example would be Volkswagen, for example. Volkswagen is a German brand, so you would not count that in the gross national income for the U.S. You would count it in the gross national product because they may have a factory in Atlanta where they're employing U.S. workers. They're manufacturing automobiles, and that production can be included in the definition of gross domestic product, but not gross domestic income. Okay. Okay, so basically, DNI is what you own. GDP is where it was made and how you're able to claim it. Now, one way of dealing with some of these variances is the concept of purchasing power parity. And this is actually a 16th century concept that ties into the law of one price. And an example of this is, let's say I have a McDonald's in the United States, and I have a McDonald's in France, and I have a McDonald's in China, and they all manufacture Big Macs. What is the relative pricing of that Big Mac in each market? Assuming that the goods to manufacture that Big Mac are standardized because they have a global supply chain. So it turns out there is a phenomenon known as the Big Mac Index because of the fact that McDonald's has such a global position that it actually can be used as a currency evaluation metric, accounting for the cost of tomato sauce and things that can vary from location. There's also something known as the iPod index, because that has become so ubiquitous. So purchasing power parity is how currency markets are able to evaluate. Now, it's not a foolproof method, and I'll use China as an example. China does not allow its currency to fluctuate. It's pegged, the renminbi is pegged to the US dollar at a rate of about 7 to 1. So when our dollar moves up and down, the yuan moves accordingly. And that's done to suppress, to keep prices low in terms of entering the U.S. market. And that's why you see a lot of skirmishes between the Federal Reserve here and the Chinese. They're always having a discussion about currency valuations because it plays a role in which direction goods and services can flow more easily. Obviously, tariffs come into play, et cetera, et cetera. So given that background, now when we define a low-income country, recognizing that these numbers are adjusted every July, I took countries that you would not always think together. So I took, so this is $1,045 a year. That's per capita income. It's total income for a family per year. Put that in perspective. Or less. So Sierra Leone, Bangladesh, and Tajikistan are examples of that classification. This puts them in a situation where they're able to qualify for certain programs from the IMF, et cetera, et cetera. Now, there's a subgroup of low-income countries called high debt low-income countries. And what the IMF and what the G8 did, the large G8 economies, convened around 2005 and basically rounded up about $40 to $45 billion of loan forgiveness, so that to take the burden off of these countries. A lot of these countries are victims of colonial powers. I'm not going to get into the political discussion on that, but I'll simply say that the burdens they face aren't always their own creation. They were gifts during the 1960s when they transitioned governments. Middle-income countries, an example of this would be Kenya, Jamaica, and Brazil. Now, if you think about it, Brazil's a BRIC nation. So, meaning that it's looked upon as they have oil offshore, they're doing extremely well, but they're still classified on a per capita definition as a middle income country. And I forgot to mention this part. When you're comparing economies, you have to pay attention to whether or not it's a per capita estimate or you're looking at total GDP. So, for example, China is one of the richest countries if you look at it per GDP. But if you look at it per capita, it's ranked 85. They have 1 billion people in that country. That money has to get chopped up in a lot of pieces. So as a Monaco, on the other hand, or Luxembourg, a very small population, has a very high income per capita and will be wealthier than the U.S., so to speak. To give you perspective, the U.S. per capita is about $53,000. I intentionally didn't put the U.S. in the high-income bracket because I wanted to get a sense of other countries. I didn't go for the usual suspects, Russia, China, Europe, etc. I put Barbados, Equatorial Guinea, and Monaco, just to show you how countries can be classified high income but have very different economic strengths based on those definitions. So the low income and middle income countries are referred to as developing countries with a caveat. Developing country is actually a term, the third world, you've heard this. These are actually terms that are not embraced anymore in the global health community. They're seen as derogatory. Developing country, these countries represent cultures that have thousands of years of history. So they don't view themselves as unsophisticated cultures. They may not have cash, so to speak, but they're culturally sophisticated. And so, therefore, in recognition of this, there's now a movement away from that type of terms, and hence the term low-income, high-income country versus developing country, even though you hear those terms used. So now that we've kind of talked a little bit about how economies are defined, we've talked about what GNI is. GNI, by the way, will be the basis for all future conversation now. In terms of the numbers that I'm going to show you, based on the residents of that country. So how do we define global health priorities? Just want to give you an example. Everyone's familiar with the Ebola outbreak. And classically, when we think about global health, we think about vaccination programs. We think about TB, we think about malaria, we think about the vaccination programs are very attractive because the thought process is very simple. Single treatment can have a lifetime of risk reduction at a tremendous cost benefit to the society. Ebola, the reason I'm showing this here is I wanted to demonstrate the interconnectedness of things. We used to think it was their problem, not our problem. But Ebola showed as a result of global travel that their problem is actually your problem. And that if Western countries or high-income countries are not investing or assisting developing countries in fortifying their healthcare infrastructure, it can come back to haunt you. Hence the Ebola outbreak. The Ebola outbreak exposed significant systems-based vulnerabilities because the infrastructure was simply not prepared to handle that level of onslaught. The reason the Ebola outbreaks occurred, theoretically, is because of deforestation, which actually put humans in closer contact with carriers, and as a result, you had contamination of humans, food, et cetera, et cetera. This was the one time, which is where the Christine Lagarde, who runs the IMF, made the following comment. She said it's okay with the IMF, and she's speaking to the developing countries. In this particular call, it was with Liberia and Sierra Leone and Guinea. She said it's okay with us for you to expand your deficits. This is an unprecedented comment because I just mentioned that the G8 got together to offset that debt. So the IMF is saying, we understand that this is such a bad problem, we need you to spend on infrastructure to get this disease under control. So what was the impact of that illness, of that disease? Turns out I can speak to Sierra Leone more specifically because I was there. They were actually in the process. Sierra Leone resides right on the Atlantic. Tropical, beautiful over there. When you go over there, you sit back and say, oh my God, the beaches, you can see where the hotels line up. And in fact, they were building a hotel when I was there. It's a status post-conflict nation. So as a result, you'll see a lot of children with conflict amputations, et cetera, so chronic pain syndromes, et cetera. So as anesthesiologists, we were looking at modalities to offset that pain by using local anesthetic and catheters. But the point is, they were actually in the process of having positive GDP. The president of Sierra Leone was invited to the White House You see Barack Obama, because of the fact they underwent 2 successful democratic UN-sanctioned elections, status post-conflict. And so they were making tremendous progress. Then Ebola hit, and look what happened to their economy. It pulled that production out of it, because are you going to continue building your hotel in the middle of an Ebola outbreak? Our team had to pull out. We weren't able to continue the work we were doing because the State Department put out a notice, as well as Johns Hopkins Institution said all U.S. citizens must return and without special approvals to go into that venue. So, in recognition of the need for improving health on a global setting, the Millennium Goals were actually set up to look at various major things. So, for example, eradicate extreme poverty and hunger. This is actually what guides Bill and Melinda Gates Foundation. They look at how a particular program is acting on these particular 8 Millennium Goals. But there's a catch here. Out of those goals, out of the global reference list for 100 core measures, these are measures put out by the Lancet Commission that actually let you know the goal is on target. So these are objective measures. So in other words, you have a goal. How do we know we're meeting the goal? 100 core measures that were agreed upon. Only one dealt with a surgical condition, and that was surgical wound infection. So clearly neglected. The process basically didn't emphasize non-communicable disease states as a major priority. Now what has happened is at the end of 2015, which is when the Millennial Goals expire, there's what is known as the post-2015 agenda, where the new goals will actually be put in place. As a result of this, the recognition that there was insufficient core measures focusing on surgical outcomes, over 100 organizations got together and wrote a letter in the Lancet with the support of the head of the World Bank, Jim Kim, who used to be the dean at Dartmouth, the president of Dartmouth, actually wrote a letter suggesting new measures that are to be incorporated in the new rollout of core measures. So these are an example of non-communicable diseases. All of these diseases are related to are amenable to surgical intervention. And we don't have time to go into all of it, but you can use your imaginations. If you have a tumor somewhere, surgery may help you. Cardiovascular disease, respiratory problems, etc. And there's also another category, injuries. Turns out 11% of the global burden of disease is injury related. Big numbers. This organization was recently formed in recognition of the neglect of the surgical issue, called the G4 Alliance: Obstetrics, Trauma, Anesthesia, and Surgery. Forgive the darkness, but that's how they made the slide. And Christiana Care recently became a member of the G4 Alliance. Myself, Dan Mira, Richard Durbin, and Omar Khan got together and decided that this was important for Christiana Care to be a part of, and I'll show you a little more. You can see this was a conference in Geneva. I don't actually know who these people are, but I just wanted to point out. I was happy that they posed in front of our and how we're associated with some major players in terms of Operation Smile, The Cure, Harvard, and other major institutions, all coming together to recognize that, and we actually have a permanent seat on the board as a result of this action, and working with the WHO in terms of driving this care. This is just a picture of the conference of ministerial leaders, and this is actually a picture of what happens when academicians think they're cool. They try to do these G4 hand signals, I guess, and they got confused. But nonetheless, they were well intended. This was actually in Switzerland last week, the day before our symposium. I brought that up because I was supposed to be at that meeting, but I couldn't make it. So the suggested alternatives, or let's say addendums to the core measures, are as follows. One is perioperative mortality rate. This is actually a very good term that we should be looking at even in the United States more comprehensively. This is all-cause mortality in the perioperative space for looking at surgical volume. So this kind of is an efficiency metric as to how your operating room and PACU in these areas are actually functioning. Surgical workforce density. Less meaningful in the States because we have very robust supply of surgeons, et cetera, and anesthesiologists here. But in countries that are resource constrained, it's extremely impactful. Sierra Leone has one anesthesiologist for the entire country. Wow. The board-certified surgeon, who was about 40 years of age, you heard his name in the news. He actually came here with an Ebola infection and unfortunately died. That was their board-certified U.S. trained surgeon. So as a result, there's a large number of provider extenders, such as nurse anesthetists, that are used. And the big discussion in the global health community is this issue of task shifting, which is even using people with lesser training to try to deal with the deficit. It is predicted that we need approximately 2.2 million more surgeons by 2030 in order to meet the deficit needs on a global basis. The problem is it takes a long time to manufacture a physician. If you think of a physician as a widget that goes through a supply chain, it takes a lot of cost and effort, and then they're not guaranteed to stay in that country. And once they receive this education, often they leave because they have opportunities elsewhere. The other issue is catastrophic and impoverishing expensing. And this has to do with the fact of if you have surgical illness and it's not treated, it actually can translate into lost wage earnings because you no longer can function. It actually can translate into if you have the resources or figure out a way to pay for your surgical care because you don't have universal coverage, all of a sudden you've wiped out your resources in your family. So the surgical illness can be extremely economically devastating in the U.S. as well as in, so one of the things that's being advocated is universal health care coverage for these countries. Sounds familiar. This was just to, not really for you to read, but just to remind me, this is fresh off the press about 3 weeks ago, that their goals to meet these various requirements, and you can see, like, for example, here at the top, it's 80% coverage by 2030, and that is, and one of the measures that's been just introduced is actually access to timely essential surgery within 2 hours, and having objective measures, what they call bellwether procedures. So a C-section, for instance. A woman should have access to that within 2 hours of needing it. And so in measuring, and hopefully to get 80% coverage by 2030 in resource-constrained environments. So when we think about cost, let me preface this comment by saying all life is precious in the eyes of God. I just want to make that comment. So I'm not necessarily conveying my personal views here. I'm just going to tell you how the world looks at it. Okay? So it turns out a life has value. It turns out certain lives have certain levels of value and certain, et cetera, et cetera. So when we think about statistical life, we're talking about a population's willingness to prevent that illness in that particular population, or death, or disability. It's not the best metric. It has weaknesses. It relies somewhat on imperfect data. Do you really know how long I'm going to live if nothing happens to me? It doesn't take into account vision issues, hearing loss. These things actually can impact your environment if you don't have the appropriate support structures. And it doesn't always, in this particular measurement, the age issue wasn't as robust as it should have been. But I want to give you an example of how it works, because we actually do it in the States, although they don't tell you. Consider you're in a population where it's adjusted to where you live, by the way. Let's say your life expectancy is 75, and where the median age is 25, and let's just make up a number that the insurance company says you're worth $1 million, more or less. Suppose you suddenly die, unexpectedly, and you're at the age of 50. The way that you would calculate this is you would contribute approximately 25 DALYs, and I'll define what that is in a moment, and basically subtract that from your predicted life expectancy, and you'd come up with a value of 500,000. This is actually what the courts do when they decide what a fair settlement should be for inappropriate death. The EPA says in the United States you're worth about $9.1 million of an entire single life. Different organizations have different insurance companies have different metrics. In the U.S., the EPA says about 9.1 million for a single life. Now, if we were to take that and translate it into non-communicable diseases, this is in trillions of dollars. These are resources. Now remember, this is the amount of money society is willing to spend to prevent that illness or disability or death. And so, using 2010 data, these are trillions of dollars. You can see that about 55% of the cost is put in the high income bracket. Okay. In terms of, however, the majority of the real burden is here. Okay. So when you're thinking about global health planning, this is how you have to put this into account. If you're a ministerial leader and you're trying to manage disease process, this is some of the things you have to take into account. So now I want to transition to global disease burden and kind of fit this in. So many of you are familiar with disability adjusted life years. Just to remind everyone, basically this is premature death, and this is years of healthy life lost due to a disability of some sort, diabetes, ischemic heart disease, that sort of thing. So basically it's numbers being taken away. When you think about quality adjusted life years, those are years added to you as a result of an intervention. Okay? So if you have PCI versus cabbage, how is that adding life, and then as a result you get an ICER score, that incremental cost effectiveness ratio that Zugway calculates. That's where that value metric would come from. So something remarkable happened. The Bill and Melinda Gates Foundation funded a study starting in 1990 to quantify the burden of disease globally. And this is on par with the Human Genome Project. That's actually over 300 statisticians, over 291 causes were identified from 187 countries. 20 age groups were broken down from both sexes, looking at key metrics and breaking it down into those actual disability adjusted life years for 291 causes. They did something else remarkable. About every 3 to 5 years, a new set of data comes out. And when they modify the metrics, they change it for all years preceding so that you can actually compare what 2000, I'll just make it up now, 2015 with 1990. Because of the way that they did the new data, when you go to the new data sets. So it allows you opportunities that are just never had in order to actually quantify burden of illness. So major findings. About 47% of DALYs worldwide were from communicable causes. And by the way, why do we care about it? I forgot to mention one thing about DALYs. The challenge you have when you're looking at disease is if you say, for example, I have ischemic heart disease or I have a stroke, how do you normalize that in terms of severity and so forth? So the DALY basically uses time, years, as a currency, and in that way you can actually compare a disease based on its disability-adjusted life year. So there are tables that have been created for all of this. So it allows you now as a ministerial health leader to really understand burden of disease and not be distracted by necessarily breast cancer versus prostate cancer versus whatever. Now you can actually look at, well, what are the disability-adjusted life years for prostate cancer in that region versus over here? And now I can understand how to allocate resources to deal with those things much more fairly, transparently. 43% were non-communicable diseases. That's important. 10% were injury-related. I brought this up before as to this is just a quick reminder of what the non-communicable diseases are in injuries. And I want to shift to the U.S. for a minute. This is data from the National Health Sample with AHRQ. And what they did, which I thought was fascinating, was they took the Global Burden of Disease framework and applied it to AHRQ data. This represents, by the way, 34 million patients. This is a huge data in the United States. And basically the question was, of all categories, communicable and non-communicable, which one of those patients who had surgery? Turned out that about 28%, the overall frequency rate of all disease burden, were surgically related, and operations were performed in every category. So for example, if you have an infectious disease like empyema, which is like pus in the lung, you need a chest tube to drain it. You may need a part of your lung resected to deal with it. So it's a connection between, so it's not just an antibiotic, but often need surgical remedies as well. The other thing they noticed was that in terms of the way the data was captured, about 20% of the GDB framework did not capture all of the inpatient operations. This is inpatient, by the way, inpatient operations. So this was a very important finding because it demonstrated that surgery is something that shouldn't be overlooked in terms of how it impacts all of the various disease categories, regardless of whether it's communicable or non-communicable. Now I want to talk a little bit about aversion. So you have, this is actually from Bickler's work, where he wanted to look at the issue of, well, if you have a particular DALY and you receive treatment, can we call that an avertible condition? And the counterfactual was, if you were to receive the same quality of care you got in a high-income country, what would the avertible burden be in terms of this? So in other words, if you go to a low-resource environment and offer what you're receiving in the high-income country, then you get a delta there, and that would be your avertible burden of illness. The basic, and he used the term basic surgical package. So he wasn't talking about exotic stereotactic brain surgery, saying that if you have a road injury, you're going to have access to basic resuscitation trauma. You'll have the necessary amputation if needed. You'll have a surgical airway made if you need it, a break, that sort of thing. Chest tubes, needle decompression. Often if you have certain types of chest injuries, you can have air that accumulates and you need acute decompression in order to breathe. And then obviously trauma-related laparotomies in case you have perforated viscus or some kind of trauma-induced abdominal injury. Surgical exploration is often needed. So this was called the basic surgical package. He left out anesthesia, though. I just had to put that in there. I was a little irritated when I read it. None of this stuff is always done asleep. I mean awake, by the way. You hope somebody's there to stabilize you. So then he broke down. I kind of got a little bit ahead of myself here. You have burden of surgical conditions, DALYs. This is if you were able to actually get the surgical care, so that would be an aversion. If you qualify but didn't get it, potentially avertible, and then sometimes you're not salvageable based on the severity of that injury. And this is broken down by super region. So here you have, for example, Latin America, the Caribbean. Here you have Central Europe, Central U.S., North Africa, etc. The yellow represents non-avertible injuries, and then the green is avertible. And I want to keep your attention here. First, you can see the burden is high in general. But this avertible cause seems small, but I'm going to show you something that may change your perspective. These are DALYs caused by injury, demonstrating that injuries are a big deal in terms of road safety. And when I was in Sierra Leone, just as a quick side note, a lot of dirt roads there. I took my wife with me on one of these trips, and I'm in the operating room doing my thing, and my wife comes back and says, "Oh, I went to church down in the city." And I said, "Well, that's great. How'd you get there?" "Oh, I rode a motorcycle." I said, "You did what?" "You rode a motorcycle." Do you realize we have a constrained environment? I'm actually in that environment. I'm not sure that's the right choice of action. For us, maybe we should opt for a little more metal, around us. But and then I got on a motorcycle myself. But having said that, but the point is, injuries are a big deal, as I mentioned, and this actually contributes. Self-harm is a big issue. There's a lot of depression and so forth. So if you were to actually compare malaria, TB, HIV, using DALYs, 214 million DALYs a year. Look at ischemic heart disease, which was the #1 ranking in the global burden of disease cause list, about 130 DALYs per year. Look what happens when you look at surgery. 401 million DALYs. Some of these are non-avertible. Look at this, 116 million. So here you can see that this is actually on par with other major illnesses. And as a result, surgical disease should be something that should be paid attention to. It also has tremendous economic burden. I'm going to skip through this. I just want to transition very quickly to give you the anesthetic landscape, and then hopefully have a few moments for questions. I mentioned to you that Sierra Leone had one anesthesiologist. And by the way, I forgot to mention, he's 70 years old. They brought him out of retirement because they needed him. The risk of death, we're not entirely sure how to quantify it, so these numbers are really guesses, but they're reported. Is about 1 to 150 to 1 to 3,000. That's an equivalent of early 19th century medicine in the U.S. Put it in perspective, about 1 in 200,000 is what you have now. Okay? So that's the disparity in terms of anesthetic risk for low resource environments. Many of these programs use non-physician care providers. This was the device that was created. And by the way, I'm not here to sell a machine, but let me just explain what this does. This is an oxygen concentrator. It takes room air and concentrates it up to 95%, thus eliminating the need for expensive piping in the walls that have to meet a certain spec and having compressed gas. It uses human power to actually deliver the anesthetic. So it can work with or without. It has electricity, but it can use a human to actually drive the machine. It gives you flow rates of gas and accurate pressure numbers, which is important when you're delivering an anesthetic. And it has safety features that prevent hypoxic mixtures. So in other words, you can't mistake nitrous for oxygen and actually suffocate somebody without knowing it. It has a lithium battery in the sensor, which allows, so if in the event of a power outage, it'll power on for about 6 to 8 hours in terms of giving you the F5 fraction of inspired oxygen concentration, so that you always know what you're doing as a safety feature. And if this breaks down, it entrains room air. into the gas mixture so that you can deliver safe anesthetic in the absence of compressed gas. Of the compressor. At the same time, it still connects up to the same stuff we have here in the States. But there's one other feature. It only costs $10,000. The U.S. machines is anywhere about 80 to 100. It uses silicone tubing that's washable, so it's not disposable. So as a result, they can autoclave the tubing. It's based, and they can wash it out with bleach, hang it up to dry, and put another one on, and not have to consistently buy. The U.S. model is based on consumption. They want you to buy more stuff. And the other thing it does, it uses one tool to take it apart. It uses two car filters inside, so it's easy to get in the local market. So they made, and so the question came up, why don't we use this in the U.S.? Guess what happened? The lobby stepped in. No, you must have all these other standards to qualify as anesthesia machine. So this is actually not certified by the FDA, but by the European, called the CE watermark, the equivalent of the FDA for Europe, is how we managed. When we did this study, we started it in the U.S., in England first, to prove to low-resource countries that they were not experiments. This was actually the team, the initial team. This is right outside the anesthesia office. These are our very first research study coordinators, fresh out of Johns Hopkins School of Public Health, and have gone on to do some extraordinary things. And these are my two colleagues. He's an adult critical care intensivist, and Benjamin Lee is a Harvard-trained epidemiologist and pediatric anesthesiologist and palliative care expert. This was when we went to meet with the government of Sierra Leone, that's the vice president, and when we were putting the deal together. And these are the various ministerial leaders. Here is the anesthesiologist in the country. Very wise man, by the way. Brilliant anesthesiologist. Trained in England. He's Ghanaian. And they brought him over because that was the way they got their one anesthesiologist in country. We're very proud of the fact that these are our study helpers, and they were all city certified. So we made sure our model was we weren't just there to collect data. We're going to actually teach and folks in country so that they can work on other projects. Fulbright scholars were there with us, and so they could actually stay employed by working with others by having the city certification. We administered the test in Sierra Leone. And this is the very first team that we assembled there. This was me teaching basic practice. These are a combination of technicians and nurse anesthetists learning safety. This machine, by the way, here was made in China at a fraction of the cost, and with a battery life of about 8 hours, which is unheard of for monitors. You can barely get that in the United States for those who do medical device work. With all of the requisite safety features that were needed, because we spec'd it out and used a Chinese manufacturer to build it. And our work made it to a TED Talk. So as a result of our efforts, actually they mentioned the study at a TED Talk about how we put this together and did it in country. And we also did simulation. This is an artificial lung that we brought down to actually create conditions of asthma, barotrauma to the chest, etc., to make sure that the trainees understood how to work the machine and under those and make those diagnoses. We even replicated power outages. That wasn't hard. They happened all the time. But we did that. This is an actual case, and you can see one of our research assistants actively collecting data. This is in Sierra Leone, pre-Ebola, and you can see the nurse anesthetist actually using the device and they're getting ready to intubate this patient. This is Malawi. This is my son. where he actually went with me there to collect data on an actual case. We were there were the Germans, the English, and we were also in Malawi looking at ways to optimize the operating room environment. So he's observing surgery and collecting data. And he's actually been in the Value Institute. There he is at an orphanage where he actually donated his football gear and used his own money to supply them with pens, pencils, and books and paper. It's actually a commodity in a resource environment. So what I wanted to do, share with you, closing, a video summarizing the talk.
Over the past 2 decades, global health has focused on individual diseases. Surgical care has been afforded low priority in the world's poorest regions, leaving 5 billion people without access to safe, affordable surgical and anesthesia care. Patients requiring surgical treatment will face multiple hurdles: delay in seeking care, delay in reaching care, delay in receiving care. Reaching the hospital does not guarantee treatment, as many lack the proper infrastructure to provide emergency surgical care. As a result, many easily treatable conditions become diseases with high fatality rates. As many as 90% of maternal deaths could be averted by timely intervention. For those who successfully obtain treatment, 1/4 will experience financial catastrophe as a result of receiving surgical care. To save lives and prevent disability, an additional 143 million surgical procedures are required annually in developing countries. Today's surgical workforce would need to double in 15 years to reach our target of 80% coverage of timely access to essential services by 2030. The total costs required to reach these targets are significant, at approximately $350 billion by 2030. However, the costs of failure are even greater. The lost output will cost developing countries an estimated $12.3 trillion. Investing in surgical services is affordable, saves lives, and promotes economic growth, making surgery an indivisible, indispensable part of healthcare.
That concludes my talk.
Well, thanks, Eric. That was really enlightening. So you said the machine, the anesthesia machine, costs $10,000. But a lot of money. $10,000. So how is it sold in developing in low-income countries? Is it now used? What's happening?
Questions. It turns out that as a result of our work, and another presentation I plan to give will actually show you the results. We're still tabulating numbers, although we had to suspend our effort a little bit because of the Ebola outbreak. Turns out Sierra Leone, as a result of what they saw, they went out and purchased 40. Turns out that governments can pay for what they want to pay for. Well, I'm being taken. Priority setting is a key principle in all of this, and appropriate partnerships are usually able to find innovative approaches to acquiring. I'm not going to say it was easy for them, but when you have data that shows you what you're paying for without knowing, and you have credible data like the Global Disease Burden study that Bill and Melinda Gates put together, now it helps the ministerial leader to make the case for providing that service. Particularly when, in our case, we were there in country. Part of our study, we left the machines for free. It was at no cost to them. That was one of the requirements we made with the foundation. We said, when we're finished with the study, can we leave the equipment and working equipment with extra things? So we actually came up with a kit that, so they have all these extra supplies. We even included digital cameras in the kit because we learned that communicating parts was hard. Just take a picture and then tell them, then the South Africans will get it there. You know, turned out that the Middle East, Middle Eastern countries purchased the machines. It turned out that Haiti actually wants the machines. Turned out that Nigeria, so and Liberia as well. So multiple countries have actually started, in Nepal as well, have actually chimed in because the machine is resilient. It doesn't break as easily. One of the big issues you have in these countries was heat and dust. And we were actually worried about this. As a quick side note, before we started the study, we had to put the machine in a warehouse. And so we realized, this is Sierra Leone, it's probably over 100 degrees in there. Will this stuff survive? So we called the manufacturer. They said, we never tested for that. We don't know. And so but it turned out the machine did just fine. It withstood the heat. There was no breaking in the plastic. Everything worked. So it was an inadvertent test. And it had to do with moisture, heat, and all the things, and and all those issues. So that's kind of the response. And they're still using it in England as well, by the way. One of the comments I made on the state side is this should be used in veterinarian offices because you can anesthetize animals very effectively with this. And in dental offices, because often they use, as an anesthesiologist, I pay attention to what kind of equipment is around. When I'm in a dental office, I don't always see the best and most sophisticated equipment. And that machine is actually much safer than what they have because a lot of dental offices do not have piped-in gas. And I'm aware of data from adverse events from sedation where some data shows that if you have an adverse event in a dental office, 91% of the time you'll die or have permanent neurologic damage. So so I asked, why not use these machines in that environment? They're cost effective and they're made to work under the most strenuous conditions. I think the implication for the U.S. is, I asked a theoretical question and I'm curious about your response. Should we be using DALYs as a way to look at disease burden at Christiana Care Hospital? Then you can have parity with disease and actually have a better understanding of disease burden as opposed to, I can't say what I'm thinking, but let's just simply say that some of the metrics we use were not really clear on do they accurately reflect the actual burden of illness. I understand we have to do CMS measures, there's no way around that, but for our own internal analysis, should we be thinking about using DALYs?
Also, from a research perspective, it would be really nice to have a standardized measure that you could apply here and compare across.
Absolutely. You could do better. UHC data would be much more interesting. In fact, that may be worth having a conversation with them. And I would actually say use the metrics that are used in the global health study, because 300 statisticians are going to have a better idea on how they've had to solve all the hurdles. So you can just borrow what they've learned, apply it to the UHC database, for example, and then give you some operational insight adjusted for U.S. currency.
Any other question? Great.
I have a quick one. Dr. Jackson, I saw something on television about a device, a computerized device that can administer certain kinds of anesthesia, things like colonoscopies, and, things where you're not like general anesthesia, I don't think. I was wondering if you knew about that or heard about that, and whether something like that would be of use in these other countries.
I'm not familiar with the device you're speaking to. If I had to guess, because you mentioned the term colonoscopy, probably an infusion pump that pushes a drug at a certain rate, and that could be used for sedation. And one of the issues, by the way, I forgot to mention this, battlefield, we're learning a lot from Afghanistan. And in fact, I took an ultrasound course last year. from the military guys at University of Maryland, just to keep my perspectives up. And so what's happening now with regional anesthesia is they've mastered the art of really blocking almost any body part. So, because you need a soldier to run, so you can block the arm, not sedate them, and you can get out of harm's way at the same time. Also, have less risk of airway obstructions and all the things that accompany that. So, so there's a lot of innovation happening. We're actually looking at regional opportunities in low-resource environments because in some respects it's cheaper. However, the catheters are, I may be saying an oxymoron here, but the catheters are expensive and you need good stewardship and sterile technique to use those devices. Thank you very much.